I would like to ask something now. You know, the term of pseudomyxoma peritoneae was attached a few years ago also to ovarian cancers, which is really not true anymore. It's really an appendiceal tumor, the origin of this. Pathology is still very controversial, and most pathologists do not know how to categorize this frequently, and this is one of the problems that we see, is that these low-grade tumors are usually mentioned, oh, this is not a cancer, don't worry about it. Oh, it's a little perforation. That's the time when you have to come to one of us. Because this is the people that we see 5 years later, 6 years later, with a terrible problem where they need a massive operation in which the success and the complications are very different. And I think that's an important thing. Then you have these categories, and again, this is the report for pathology was done by a group in Hopkins a few years ago, which really only talked about close to 100 patients, which was a combination of cases, and kind of people adapted from those, from that report. But really, the pathology is not well known right now. You know, and there's an effort by a lot of groups trying to, how do we categorize these patients? Because now, when a surgeon tells you, listen, oh, you have a 100% chance of doing well because you have DPOM, that's not true. Why? Because that low-grade tumor, there is 20% of those patients who are not going to do very well. They'll reoccur either because it's really, even though most of the tumor is mutant, there are some more aggressive cells that tend to reoccur. We have seen patients that in the same appendix, they have actually an aggressive component in it. You know, a very nice picture that show that and how they are going to behave. There is not going to way to predict. We also have a group of patients who are the signaling cells. Now that's you have to be very careful how you categorize that, because having 2 or 3 signaling cells doesn't necessarily mean you're going to do bad. We define a signaling carcinoma when you have more than 50% of the tumor. Again, that is also very arbitrary. I mean, no one knows the answer, but it's a more consistent tumor. But I don't want you to think that just because someone tells you you are going to have a signet cell, you're going to die. You just need the right.
You could technically then have signet cell, but also have DPAM at the same.
Yeah, but I mean, the only thing,
it only means one section, that section right there. That doesn't mean the entire cancerous part is all signet cell.
Yeah, but also, not all the bad cancers that look bad act bad.
Right.
They are most likely to act bad, but not necessarily. You can cure, you know, these patients, and you may not cure the good ones either, you know, depending on who you are. So do not hang yourself just on that definition. You know, you just need the right physician to take care of you.
Right.
And something that I've seen a lot in my practice is people come with the study that Dr. Sardi was referring to out of Johns Hopkins, the Rennett criteria of how to describe these tumors. And it's a very nice way of categorizing these tumors, and in that study they really did show, again, some of the prognostic potential of the way of categorizing these tumors based on how many cells there are versus how much mucin there is. And so a lot of people would come with this, you know, asking, where do I fall on this Rennett criteria? But not every hospital uses that criteria. So that group has formulated that criteria and sticks to it. But as you go around to different hospitals or you meet different surgeons and different pathologists, they don't necessarily use that nomenclature. And that that's not necessarily a bad thing. If you're at an institution where you have somebody who sees a lot of these and works closely with their pathologist, what you will find is that their pathologist will describe these tumors in a certain way that the surgeon recognizes. What does this mean? What can I expect to find at the time of surgery? So again, it's an issue of that level of awareness and working with somebody who's seen a lot of these, who works with a pathologist who's, you know, they work together and they know what it is they're looking at under the microscope and how this might behave and whether or not, how that's going to impact surgery at the time.
I mean, I think there was something actually in all 3 of your answers that leads to why I think I categorized diagnosis and education together, which is, you just focused on Dr. Lambert. Pathologists who see this a lot have a way that they look at it and understand it. But I think one of the questions that we heard a lot was from patients was, what's the priority in the medical community at large, or who should we be aiming at in terms of increasing awareness of how to recognize the disease? Is it pathologists at large in the world? Is it GYN surgeons in the world, et cetera, is it primary care physicians? Because I think something Dr. Sardi said earlier was, if patients can get to you sooner, the treatment can be more effective. That one of the biggest problems is people aren't getting the treatment until 5 years of treatment that really wasn't the right thing to do. And so what's the right part of the medical community to focus on in terms of front-end loading the education to get the right diagnosis?